Good afternoon, colleagues. My name is Pius Pungwayo and I'll be leading today. I hope everyone is okay. So at this moment, let me allow my team to kindly introduce themselves.
Good afternoon, colleagues. My name is Mercy Shabam. I'm with the Hospice team. Good afternoon, colleagues. My name is ECHO-Eswatini. I'm also with the Hospice team.
Afternoon, colleagues. My name is Sandile from Eswatini Hospice at home. I'm with the HAP team.
Good afternoon, colleagues. My name is Noel Abuteka. I'm also with the Hospice team.
Good afternoon, colleagues. My name is Brenda.
Thank you very much, team, for the welcome, for the introductions. May I kindly request our online participants to kindly introduce themselves. We'll start with Zamobuhle Lukele.
Good afternoon, colleagues. My name is Zamobuhle Lukele from the Eswatini Cancer Control Unit.
Thank you, Zamobuhle. May we move along to Thandazile Smelane. Thandazile, are you there?
Sorry, just a second, my dear. I'm here. Good afternoon, colleagues. Am I audible?
Yes, you are audible, Thandazile. Go ahead.
Okay. Yes. It's Thandazile Smelane here from Manzini Government Hospital. I'll be joining from a different room, but the rest of the team will be joining from the other room. I believe they'll introduce themselves.
Thank you, Thandazile. May we move to Bongi Mabuza?
Sanmolane.
Hello.
Good afternoon. My name is Bongi Mabuza from Pittsburgh Government Hospital.
Thank you, Mr. Mabuza. May we move to Nana Shandu? Nana Shandu, are you there?
Good afternoon, team. It's Nana Shandu here from Manzini Government Hospital. I'm with Sister Lungile Masugu and Portia Dlamini.
Thank you, Shandu. May we move along to Trustee Mbata?
My connection is unstable here.
Trustee, are you there?
Afternoon.
Afternoon.
Afternoon. Trustee Mbata from.
Okay, thank you very much, colleagues, for your introductions. May we end with Malaika. Malaika, may you introduce yourself?
Hello everyone, I'm Malaika. I am from ECHO India and I'm executive head. Thank you.
Thank you, Malaika. So on our last session, colleagues, we tackled the topic on advanced conversions and opioid side effects. So our last presenter, which is Ms. Tani, presented. So we will give her the platform at this juncture to briefly give us feedback on the case that she presented. Over to you, Tani.
Thank you, Pius. Good evening, good afternoon once again, colleagues. I'll be giving you feedback on our case for the previous session, of which we had a 27-year-old client who was defaulting at several times and was now on stage 4 of WHO and clinical stage for HIV. Unfortunately, with our client, he then passed away on the Friday of that same week we presented. the family called to inform us that the client has passed on, and which is even more unfortunate is that the caregiver, whom I had reported prior that he was feeling burdened, when he was told of the news that his son has now passed away, he also passed away immediately after hearing the news. So we have since gotten in touch with the family to have an appointment for bereavement counseling. Otherwise, our psychologist who offered Mrs. Ntengwenya, we were in touch with her. She also said she is still available for the bereavement services. So we will update probably once again once we have done the bereavement counseling. Thank you.
Thank you very much, Ms. Tani, for the feedback, and condolences to the patient's family. Please be reminded that we, at all times, let's try to keep our phones or our gadgets on silent mode to avoid any disruptions. Also, for any comment that one may wish to verbalize, you feel free to comment on the chat box. You, with recognition of the leader, you'll be allowed to unmute yourself, then you may voice whatever you'd like to voice. So today's session, our didactic session will be led by Mr. Mahlang, and Dr. Ntipane will be co-hosting, which is on special populations and patient-controlled analgesia. So they will be tackling this topic together. I'll give this platform to them at this moment.
Hi everyone. Maybe while I'm still trying to upload our presentation, may I give you colleagues the opportunity maybe to reflect and comment on our previous case presentation from who has already been with the Lord, together with the caregiver, on what you can say concerning that last session case, while I'm still maybe trying to upload our presentation. Is there anyone who may want to say something concerning our patient? The patient is the one who has defaulted at and was bedridden. Do we still all remember, especially as we were there? Is there anything we can like to share or comment concerning that patient?
Thank you very much, Madam, for this small opportunity. For me, I was just wondering in my mind if our client did have a good day. But as I look at things, no, it was not a good day. Because at the end, I understand he himself was not able to talk, but maybe those actions I would put in my mind that he was trying to say something of which he didn't at the last moment. Thank you.
Thank you. Okay, thank you, Auntie Sibongile, for that. Now, today, we will be looking at special populations and patient-controlled analgesia. Let me bring to attention, colleagues, that we are almost there, rounding up our series on pain assessment and on pain management, especially non-pharmacological and pharmacological measures. So we are now beginning to go a little bit down. I think if you are still interested to know what we started on defining pain to where we are now. So you can access our materials from the previous sessions on our YouTube channel, or you can also check our session on the ECHO platform where you are registered. You have access to those materials, and all things concerning this series is available in our platform, so you can go back and check. But last session, we talked about the advanced conversions on how we move from one opioid to the other, and how safely we can do that without harming the patient. So today we'll be looking closer to how then do we deal with special populations and patient control analgesia. We won't dig that much in terms of patient control analgesia because it's something that is new of how we can manage opioids, but we'll look closer to the special populations and how best we can support them. So in one or the other, in our care, in our population, after the AIDS era, we are experiencing a high number of special populations, and with the incidence of cancer and other ailments, we are seeing more specialized population coming up and in need of palliative care. So we will be looking at how best we can do that in terms of management. So by the end of this session, we will be able to utilize best practices when prescribing opioids for special patient population and manage pain in imminently dying patients, older adults, and cognitively impaired patients and children, and recognize indications for starting patient control analgesia. We will not dig much on that one because it's still new and it's a more detailed one. I'm aware that Dr. Ndibane will not make it now due to other commitments. But let me just say the special attention, the special population people will be looking closer to the imminently dying, the older adults, and cognitively impaired and children. There's nothing so nice and soul building to have a patient who will die in peace. You know, that's the sole need for us, that if death comes, our patients are not dying in pain, but they die in comfort. So then the question is, when we are dealing with the patients who are dying, many of the patients and families, they have different fears on pain management, especially in the final hours and days of their lives. And sometimes one of the questions that we usually have is it still fit enough for me to continue to give all medications to my dying patient or a patient at the end of life? And the answer is that not all medications can be given to people who are at end of life. But even those drugs we can withdraw, as we talked about it in our early presentations last year in terms of ethics and consideration in palliative care of withdrawal and withholding. And some of the drugs we can withdraw, withhold, we cannot at any point in time withhold or withdraw pain medication. So even though there are many myths around that one, so we need to help our families and patients deal with those myths in terms of a person who is imminently dying will always need pain control, because the major goal of palliative care is to ensure that the patient, even if he dies or she dies in comfort. Family members and some healthcare professionals fear that opioid use may hasten death. You know that one of the side effects of morphine, we've been saying it more than again and again, that one of it, it's like a sedation. Some people will feel like sedated, but then there is no way opioids can lead to death to a dying patient, right? As long as those opioids are administered appropriately, those patients who are dying, let's help them die. Actually, the guidelines are making it clear that a low dose of morphine, especially the immediate release formula, can ease breathlessness, especially at end of life. So you'll find that a patient at the end, I don't know what happens, you're going to die because breath changes, respiratory patterns changes, but breathlessness, once it's there, you can just give 1.25 milligrams of morphine, which is the lowest dose of morphine, and then you will find that the patient will stabilize the breath and you will die in peace. Can you imagine having a patient dying in peace in your hands? That can be very comforting. So there are different duties that we have at end of life as clinicians. So the responsibility of a clinician is to safely and effectively treat pain at the end of life. So the rationale for us to do that is that studies have shown that the relationship between opioid dose and survival or time of death. So there's no relationship that you are in opioids and then you will die at this time. No. So in short, there's no effect, that much negative effect of using opioid at the time of death. So another thing is that anxiety from uncontrolled pain and shortness of breath may actually hasten death, as I've mentioned. So the anxiety, the desire that happens there may make death to be hasten. Patient and family members need to be educated that pain and other symptoms can be safely treated during the final days to our lives. So we need to know that in the final hours of life, we can still manage those symptoms very well. And then one of them is pain, and you need to manage it very well. Pain management at the end of life requires a balance between pain relief and patient alertness, right? You need to know, you need to balance the two. You don't need to kill the patient or sedate the patient into non-alertness so that the patient cannot even give you a blessing as a healthcare worker. So you need to balance the two, unless there's a need to use palliative care sedation, as we discussed in previous presentations when we talk about ethics. The patient may choose to trade symptom relief to alertness in the last days or hours of life. You know, why this? In short, it's pushing us that even if we want to control pain at the end of life, actually the patient is still the center of care and he's still the one to consent for that. For example, a patient might want to have time with the relatives until the last breath, and then feeling like if I take morphine, I will then be in a sleep for a moment, then I will forget things that I want to do. Then the patient will say, you know what, I value to be with my family than to take the opioid. So they will trade. They will say, no, I don't want pain control at this time around, I want this at this point in time. So we also have to respect that too. And then when we look at pain management at the end of life, especially the terms of route administration, we need to understand that almost 70% of patients with serious illness will become unable to take oral medication during their illness, especially late in the course. One of the signs that death is imminent is NPO. Patient will be unable to take anything by mouth. And then we'll know these are signs that the patient might die at any point in time. And then remember the principle of opioid administration or pain medication or management is that the pain management of the pain medicine must be administered by the mouth. But then at the end of life, then there's a challenge that the mouth might not be able to help us administer that. Then what do? Then we look for an alternative route to the oral should be prescribed before pain crisis occur due to the patient's inability to swallow pills. We need to verify. We know that the patient at some point will go. What we need to do then is to find an alternative. And then we discuss with the patient, should you not be able to take the medication by mouth, we will use this route so that we work together with the patient, because some of the routes may not be culturally good for an adult male in the country compared to a child. For example, if you are going to use rectal administration of the opioid, sometimes the elderly will not be friendly with that. But then the alternatives will include, if the patient was on long-acting tablet, a morphine, for example, you change to a liquid one. At least that one will be able to absorb by the mucosal membranes or will be able to be swallowed. So then we can opt for sometimes the rectal ones, we get some pills to do that one. And then we can opt for intravenous ones, but then depending if the setting of the patient where he is permits us to do intravenous, looking at the risk that comes with intravenous infusion of the opioids. And then sometimes we go to subcut, and we are going to a subcut administration. Sometimes the available formulas of drugs for that, it's morphine and then the hydromorphine and then sometimes fentanyl. So we need to look around that one. But remember, if you're going to use the subcut and IV, we need to stick to the conventions and follow the table of opioid conventions. And then there's also that common scary symptom that normally comes, which is myoclonic ejecting, especially at the end of life. So it's an irregular rhythm and aptitude is followed by the restriction. So the person will be checking up and down. So myoclonic checking can occur at any time during opioid therapy, but is seen more frequently near the end of life, when the patient is about to go. So even there, what can we do to control this checking? We can give hydration, we can give opioid rotation, then we can opt for benzodiazepine, diazepam. What we can also encourage at this point in time is consultation with the physicians or the specialists there, so they can then advise you better on how best you can manage this one. The important thing we need to understand about people at the end of life is that managing pain from the patient at the end of life requires balancing the need for pain control, the risk of the opioid side effects, and the concerns of the patient and the families. You need to find balance here. And for you to be able to find the balance here, you need to remember the ethical principles, which is autonomy, beneficence, malfeasance, justice. And then the other principle in terms of honesty, you need to be honest to them. You need to remember what exactly you are doing will end up affecting the patient. So, but you need to find the balance. We don't force things, but we have to find the balance. If it's it's worth it. Is it worth it? Are their consent worthy the comfort or the needs of the patient? Is the medication very worthy in terms of the side effect it can give us at this time? Because we don't want to kill our patient with side effects. We know in opioid control, there are what you call the double effect, whereby I wanted to have this effect, but then the package comes. So we also want that. We are aware of the double effect, so we need to be mindful of it too. And then we have the old adults, the aged, these ones who are already old, and we understand about into developmental stages and physiological anatomy. We know how does old people bodies react or function. Almost, I usually say they are literally like children, but who are very old, because how they work. Like, for example, you need to be mindful of how the treatment is going to work. You must pay attention to their efficacy and side effects when prescribing to this population, especially you look at the impaired drug metabolism. Older people metabolism rate has been changed. So if you're prescribing drugs that require aggressive metabolism, you might have a challenge. Sometimes impaired excretion due renal or liver dysfunction. You need to consider that one when you're talking of these people. We talk of limited physical and cognitive reserve. Sometimes with frailty, very a chaotic patient, a patient who's has lost a significant weight. So you need to also be cautious of such patients, especially when it comes to this adult one. They cannot be receive doses like everyone. So factors to be considered, mostly the common one is to pay. The first thing you need to do before prescribing any medication, actually not even opioids, is to perform a comprehensive pain assessment. Even if it's Panado, people who are very old, you'll discover that they are not going to take 3 milligrams in a day. They won't be able to take that. You will need to maybe to go down by half of that. So, or else they will not even take the 4. So we need to monitor that one very closely. And then we need to match the appropriate drug to the pain assessment. We need to be very cautious. Does this drug match the pain assessment that are found? Then consider the following factors before initiating any opioid: the potential risk and side effects of that opioid to that adult person, the safe administration route of delivery. Which one will be safe for this adult person? Who prescribes and administers the medication, right? That one must be considered. Who will help the old woman or old man to take the medication? If I'm going to get an 80-year-old person or 90-year-old and then say you will take 2.5 milligrams of meals of morphine, the 2.5 might not be 2.5. So I need to know, will this person be able to read the syringe? So will be able to give it correctly? If I say every 4 hours, will this cocoa be able to read the watch so that I can be able to do that? Some medications will require them to procure somewhere else. So I need to also consider their affordability. Will I not drain the grant? In a country, more of the grant is less when it comes to the elderly, that they can afford many things. So I need to see if they can afford. Even in terms of will the drug be available for them too? So another thing to consider is opioid pharmacokinetics change with normal physiologic aging due to the administered creatinine clearance and volume of distribution. I cannot overemphasize Dr. Smetlana's presentation, which was so critical in terms of the test that needs to be done in consideration, especially when you're dealing with opioids, with especially morphine, the liver and the kidneys. They are very critical to be assessed and be sure they are working very well, especially with these people. To account for this possibility, use lower doses when prescribing opioids to older adults. So if you are starting the dose, we have been saying many times always that there might be a diminished creatinine clearance or volume of distribution. Then what I need to do is to start on a lower dose and monitor my patient, how he is, she, or he's doing. And other common issues should be considered for the adults, older adults, includes like polypharmacy. Oh, you know, our people, especially us in Swaziland, the sick ones, they like polypharmacies. Actually, they have small pharmacies at homes. So we need to deal with those issues. You know, a patient has a lot pile of medication. Actually, now they have bigger bags. You will find them at home having a pool of bags. If you are in a facility, sometimes request them to bring all their medication when they come to hospital. So you can tell how many drugs does Gogo take. So you will then be able to say, we stop this one, we stop this one, it will help. Some of them, they have many comorbidities behind. He's taking arthritis medication, he's taking hypertension medication, he's taking diabetes medication, he's taking many supplements, some from different suppliers. So we need to see how much is the kidney, the liver gonna work when I add this drug. Then the multiple comorbidities, I cannot emphasize what other conditions are there from the patient. So I know. So I'm not pushing the patient into other issues. Increased risk from side effects. So you also check increased risk from the side effects. Will this not? For example, Coco has already have bowel function issues, cannot pass stool very well, or is already bedridden. If you are prescribing an opioid, you will need to be very cautious so that you know what prophylactic medication you have to provide the showcase to manage those things. And then the education you will give them on what to do. Okay, so there are many non-opioid therapies that you can follow through, but I will not cover much on this because our next presentation will end up covering this in depth. So we need to look at physical and occupational therapy. We need to look at massage and resection techniques. We need to look at cognitive behavioral therapy, patient and caregiver education. That one is very key. We need to emphasize those things when we are dealing with these patients. So then how do we go about prescribing for an older adults? They are different. There are those who are tolerant, who are already been there on the drug, and then there's those who are new, the naive ones. If it's the naive, it's the same principle we've been discussing before, that begin with the lowest possible starting dose, right? And then you will titrate slowly and observe how the patient is tolerating the side effects and the drug. It may be necessary to cut the pills or use liquid formulation. Prolong the dosing interval from 4 to 6 hours sometimes in the context of diminished renal or hepatic function, and monitor closely for efficacy and side effects. Dr. Smetlana mentioned that one. I cannot go back that much. It's there in our presentation. That one is very key to see how effective is the drug working and are the side effects being managed or accepted well. And then for those ones who have tolerant patient, You just titrate more slowly to avoid staking and increase dose by smaller increments. So you titrate slowly, so you can see if it is working for them. The general principle we've been saying it even in other alters is the same. Start slow and go slow. There's no rush, because at the end of the day, we don't want the side effects to happen. Monitor side effects and pain relief closely. Look at it closer. How is the balancing? So that should then there are adverse effects there, you are able to intervene quick as possible. And be mindful of polypharmacy. I don't know how I will add this one. If it's possible, when before prescribing further pain medication for any patient, request them to bring all the medications at home, because they have a tendency to leave the lunch bag at home, because there's a lunch bag there full of the medication. Some they have these mashangani bags and full of medications. So request the caregivers to bring all medications to facility for review. You will be surprised. You are taking so much. Even encourage them to bring even the ones they've procured from independent pharmacies and those they've been given by these walking on feet pharmacists. Because we have those who are on the street who are selling products we cannot mention here. We know them as healthcare workers. Let them bring them so you can assess and see how much loading the patient is, especially the older adults, you know, they take advantage of them. They go to get their pension, they bring their products. And the gogos don't know. They will buy diclo 5 times and they will take 5 tablets of 50 milligrams of diclo. They are different suppliers. So we need to check and monitor those things. Most patients, so for those who are cognitively impaired, this is what we can look around in terms of them. Most of these patients with mild to moderate cognitive impairment can report pain reliably. So we need to engage them, not just sideline them. So sometimes then, as we mentioned initially when we were starting how to assess patients who are cognitively impaired, we mentioned that most of the time we rely on the caregivers. I see Zamo there specifying that is KFT and LFT for all clients before prescription of morphine or only for special population. It's a best practice for all, but sometimes you'll find that they will talk of the economy. But I believe Dr. Dlamini can concur that it is mandated, it is advisable to do the baseline so that you know how the patient is on starting the opioid, so you can know how they are working. It's not for specifically the older adults. It's that these ones, they are prone to most of the side effects. So I was saying that when you are getting the information in terms of pain assessment for the cognitively, please ensure you also engage the caregivers. But if they are able to respond, especially those who are not mild and moderate, they will do so. So to create a safe and effective pain management plan for the cognitively impaired patient, as clinicians, we must take extra precautions before prescribing and must ensure that a trusted family member or caregiver will monitor medication administration efficacy and side effects. Let me emphasize it again. A trusted family member. If we are doing assessment for substance use, risk of substance use disorder, you better also assess this trusted family member, because you will find them smoking the morphine or drinking. They will be misusing those drugs. So some will be stealing them. You will see the patient coming back after 2 and say, my grandson has taken my medication. So we need to trust them and then ensure they monitor how is it administered. A functional assessment, we talked about flag scale. Let me not emphasize much on this, but for the cognitively impaired, we are saying we use the flag scale, where we observe signs for pain during dressing or post-discharge or when we're looking at the patient. If the pain is consistently associated with discrete activities such as dressing changes, so we use preemptive analgesia before the activity. You don't allow them to burn in pain. So we use the flag scale. We talked about it on how best we can use a flag scale. So in the functional assessment, look for behaviors that communicate pain, such as agitation, grimacing, knitting, brow, and change in nausea. So we use this one. And always rule out other common causes of agitation, such as urinary retention and constipation, before prescribing analgesics, because these patients, they cannot communicate. So sometimes they will have this agitation because of other problems. Never assume that a patient or caregiver understand. Okay, this one is for when you are planning them to educate. This one you are trusting, the family member who is trusted. Don't assume they understand what you have told them. Even it's me who is a nurse, never at any point in time assume I understand what you're saying. Even if I'm nodding, find a way to see if I'm understanding. And one to make sure how you are saying it is to make sure your instructions were clear and understood. Always ask the patient or caregiver to tell you how they will take the medicine and what they will watch out for. And so they teach you back, then you will know they've got what you were telling them. So start with very low. I cannot ever emphasize that one. Monitor the functional changes in the cognitive patient. But then let me just go to the emphasis of that. When you're talking of initiating or prescribing medication, codeine is contraindicated for all patients with renal and hepatic function. It's not allowed. So don't give them codeine, because for the body to use codeine as an opioid, it has to metabolize it back to morphine. So we need the liver, we need the kidney space. So we cannot then use codeine for that. Let alone saying avoid the fixed combination, as Mr. Villa in previous sessions has encouraged us not to run away from fixed combination drugs, but then not prescribe to these patients because it will not help them. Then we have children. When treating a child in pain, I will not deal that much in this one because it's a specialty on its own. But then it is recommended that use a specific pain assessment tools and techniques like the face one, the Wonga face scale. Use child-friendly tools that the child can able to interpret and tell you how she feels the pain or he feels. Use multimodal pharmacology, cognitive, behavioral, and physical, and multidisciplinary approach to pain management in children. These are special people, so, and here it involves the children, the families, and tailor interventions to the child. You involve the family, and interventions must be specific to the child. Pain can be measured by self-report, which is considered by the gold standard, right? But then also you can use change in behavior over the time. Children can change and deny that they are in pain if they feel they are not supposed to be brave, or they feel like they need to be brave in this situation, or they are fearful. So we need to be cautious on how we assess them. And we need to look at the capacity of the child to report the pain. And whenever we are asking a question, we must be patient and use words familiar to the child. So you must need to know how the child communicates, meaning we need also to understand the developmental stages and communications of a child, so we can support them to do that. So a preferred route of administration, the oral route is often and most comfortable for pain management in children, so we always opt for that. And we use adjuvant drugs in case of appropriate, and always prescribe laxatives with an opioid, even for children. Don't leave the laxatives, always. Sometimes we'll give them the morphine and forget about the laxative, and the child will be screaming at home because of constipation. Pediatric dosing is based on weight, so we remember that one. It's based on weight. We need to get the guidelines for specialists if we don't know. So always ask if you are not sure what to give the child, and reference to the guidelines. If I'm not sure, let me approach pediatric specialists to support or assist me on how best I can manage the pain of that child. So maybe for the specialist, is that what I can say? Then for the PCA, the pain patient control analgesia, this one is a new model to help us for patients to manage pain. So it's a technique allowing patient to safely administer parenteral analgesia. The advantages are shortened time to analgesic effect. So the patient is always able to treat herself. and greater patient control over pain. The patient feel in control, like I'm able to manage my pain. And the basal infusion and rescue doses, they are able to be controlled for the patient, so the patient can do it himself other than requiring a nurse to be there to monitor the one. So the patient take the medication and they help themselves, but this one is the parenteral one. So characteristics that are indicators for use of the parenteral control analgesic is still new. Maybe you can see it in the private. I've not seen it in a government facility, but there's this pump that the patient will monitor in terms of administration of the opioids. It requires parenteral analgesia, so the patient must require parenteral analgesia and must have unpredictable breakthrough pain that comes nowhere, and rapid dose finding in acute severe pain. So we need to find the dose and control it. And the patient must be cognitive and physical capacity to use the PCA, so must be able and aware how can I use this, not because he cannot. And we cannot use PCA on a cognitive impaired patient or patient who need short-term need for analgesia, because they might end up abusing this drug. Or they lack manual dexterity, they cannot hold the syringe, they cannot do anything with their hands. So we want people who can fully functionally do it. So we also we can say that one, may I pass this one? So the administration will be continuous pain, so they use basal opioid infusion. And incident pain, they use incident or breakthrough pain, and then there's continuous incident or breakthrough pain, basal opioid infusion, and bolus doses. So when it's breakthrough, they use the bolus doses. And then when it's continuous incident pain, then they combine the two, the continuous and the breakthrough pain, to come up with the both basal opioid infusion together with the bolus. So the same models we have been talking about in terms of initiating the opioid is the same here. You calculate the current total daily opioid dose, then you convert to a daily IV equivalent, then you find the hourly continuous infusion rate, then you prescribe the bolus dose for the breakthrough pain. But I think it's another issue. On some point in time, we can then look around at it and how best we can do it, this one. Then EPCA, the good thing about it is that it allows for more immediate relief of incident and breakthrough pain than clinician administered parenteral opioid, and can provide patients with greater sense of personal control over their pain. So in short, the PCA is trying to say not only the opioid ones we can work on in terms of trusting the patient they will administer themselves correctly, but also the parenteral ones, you can use the PCAs and do it and help the patient to do that. But sometimes it can be better to start it in an inpatient unit and see if they are able to monitor themselves and administer the opioid. Then you can then give them to go home. If then the equipment, especially the devices, especially the pumps you have that can help them to administer either infusion or a bolus, then they will be able to do that easily at home. Then it can save us time and money. And thank you so much for attending and for this presentation.
Thank you very much, Mr. Mashlang, for such an informative presentation. One has noted that anxiety from uncontrolled pain or shortness of breath may hasten death. So colleagues, let me urge you to always try to allay anxiety in our palliative patients and effectively manage pain, so to curb sudden death. Also, I think it is worth of noting that codeine is contraindicated in patients with hepatic or renal failure. At this moment, let me welcome questions or any areas in need of clarity. Any questions? Let's move along, colleagues, to our today's case. If there are any questions, please do feel free to comment on our chat box. So our case today, our case presenter is Thandazile Smelane, Manzini Government Palliative Care Nurse. Over to you, Thandazile.
Once again, good afternoon, everyone.
Good afternoon.
Oh yeah, I was actually hoping for that. Thank you. Thank you so much for creating this platform for us. And thank you so much for the presentation, Mr. Mahlangu. That was quite insightful. And I even wish we could have gotten the presentation before we actually did the case. Please, you will pardon us. We were trying to come up with something like in a very short notice. So if you notice a bit of gaps here and there, feel free to actually highlight so that we also get a chance to learn. Otherwise, yes, we tried hard to get a case that will be aligned or that will kind of take a slant towards today's presentation. So we managed to get one. We have a 34 years old female with breast cancer. She's now stage 2-4A. It's a progression because she had initially the baseline one was she was stage 3C, and she did a surgery. She removed the right breast, mastectomy. Oh my word! No. I think you are sharing a wrong you are sharing a wrong presentation. There is an edited one. Let me see. There's an edited one. I sent two presentations, and I requested that you disregard the first presentation.
Okay, maybe you can continue narrate. We'll put it on screen once we get it now. Do you have it on the side?
Okay, can you just give me like two seconds? I'll move to the other side so that I open my own presentation here.
Okay. Okay, you can share
I'll be
it.
joining the other guys.
Are you using a laptop?
Yeah, I'm using a laptop.
Okay. Can we give you the rights to share, then you share it?
Okay. You know, technology will catch up with us. What we can do now.
Okay. You can continue it. We'll find it and upload it.
Okay. Sorry. Can you allow me to leave from this laptop?
Pardon? Okay. Do you see it? No problem. We'll come to it later. How far are you now?
Okay, sorry, they didn't unmute the side. Sorry. Okay, are you able to hear me though?
Yes, we are able to hear you.
Okay, thank you. So I'll be using the other laptop. Then I'm avoiding sharing the screen this side because it might take like much longer. So I'll be presenting from the edited version. So yes, we are having a 34-year-old female with breast cancer. It's a progression because initially she had done a mastectomy, but then within a very short space of time, she presented with a more complicated condition. She is now at the staging, it's T4A, yet the baseline was stage 3C. So yes, it is a progression. But also we have she's also someone who is living with a mental health disorder. It's mania, and it's a relapse. It's the bad one. It's bad mania, a relapse. So our main problem here is that we are having a disease progression despite a surgical intervention, which was the mastectomy on the right breast. So it is still progressing from stage 3C to T4A. And also we're having a problem with pain management. So our concern here is that with our client, the stresses she has, we'll get into that in a minute. The stresses that she has are actually exacerbating her psychological pain, which is manifested by severe agitation, maybe not necessarily severe agitation, but it is manifested by agitation and anxiety, and also physical pain on the lesion. There's also increased tumor pain. There's also reddening around the tumor site. So basically the physical pain on the lesion, the increased tumor pain, and the reddening of around the tumor site are basically one of the stresses which make her feel like so anxious and become so agitated. So some of those stresses, like your reddening around the tumor size, the increased pain on the tumor, as a part of a side effect, could be part of side effects of the treatment that she is currently on, because she was switched from the initial chemotherapy, which was paclitaxel, geomycin. So she's currently on tamoxifen. So amongst other things, tamoxifen can actually worsen the pain on the tumor site, can actually worsen the reddening around the tumor. And for the client, the bleeding and the pain and the reddening around the tumor, for her, we think, okay. Oh yeah, that's the one. We feel that the client actually directly associates the bleeding, because sometimes it gets severe. She directly associates the bleeding, pain on the tumor site, and the reddening. She associates it with severe pain, because each time you ask her about pain, she will tell you that she's experiencing severe pain because the wound is bleeding, because she's seeing a kind of inflammation or reddening around the tumor. So then we have to kind of balance whether the client is actually experiencing severe pain or it's because of the exacerbated agitation and anxiety due to what she is actually seeing, the bleeding and the reddening around the tumor site. So basically for her, trying to scale or kind of score the pain, it becomes a bit of a hassle, because for someone who is in severe pain, you'd probably expect the person to be have problems with sleeping patterns, probably with mobility and stuff. But for her, she's usually okay, but then she would report severe pain, like with a score of about 4 to 5. So now we have to kind of try to find a balance, whether she understands what she's talking about, or it's because she's seeing this, you're bleeding, you're reddening around the tumor. Yes, the chief complaint on arrival was bleeding on the tumor site, masses around the incision site, because after the mastectomy, she was okay, but now she's seeing multiple masses growing around the initial incision site. And also there is a seroma. A seroma is basically a collection of clear fluid under the skin. So she also noticed the seroma, which was also bothering her quite a bit. Then she was already reporting pain on the side, pain which is radiating to the axilla area. So she was obviously worrying about the masses, the fluid collection, and the bleeding. And on our assessment, her the social aspect of it, she is a married woman, but unfortunately, when you talk to her about the marriage, she tells you that she no longer wants to be in her matrimonial home. She no longer wants to be with the husband she's with. And she's also a mother of 3. She has twins, 2 twins. I mean, she has twins, 1 set of twins, and a girl. Their ages are 12 and 9. So she's currently living with her parents. She went back to her parental home, and she's dependent on the family now, which is the parents and the siblings, of which they are also struggling on their own. They are in their income, or should I say income? Basically, the parents are dependent on a social grant. There isn't much income for the parents and the siblings. Yes, she does mention that after leaving the husband or her matrimonial home, she is considering remarrying if she gets better and she finds a man. Her spirituality, yes, she has support, and she says she finds comfort in having her parents around, and she has God as a source of her strength and hope. Physical assessment, yes, there is that unilateral mastectomy. The bleeding is obvious. There is also pain, which she reports. There is the seroma, and functionality now she's ECHO-1. And emotionally, she's usually stressed because of the bleeding, the masses, the seroma, and the pain. But whether she has insight of where we are and like understanding the staging, for now, we think she doesn't have insight, so it might not necessarily be something that is actually directly bothering her. What actually bothers her right now, it's the issue of the bleeding, the muscles, the seroma, and the pain. Unfortunately, considering her condition, because once she has stresses, then it actually exacerbates the symptoms of the mania. So we felt like maybe we cannot directly discuss the staging with her. So we need the family to come and have a discussion around that. Unfortunately, as yet, so we haven't managed to get them come and have that discussion. Yes, the social worker has been able to go do a home visit, engage the family. However, the clinical aspect of it hasn't been dealt with much. We will get to that as well. Our physical pain assessment using it's PQRST. I don't know where that all comes from. Yes, we assess the pain, which is basically the pain on the right breast. And it has been there for more than like 8 months. Characteristic, yes, it's throbbing pain. Sometimes she says it's pulsating pain. And we move forward. Score, it's 4 to 5 according to what the client reports. Yes, the pain comes and goes, particularly after taking the medication. Otherwise, she's not sure if there are any relieving factors apart from the pain medication, and she's not quite sure what actually makes the pain worse. Yes, does pain affect sleep? She usually says no. In fact, most often than not, she's drowsy. So according to her, she's able to sleep. She doesn't wake up from a sleep because of the pain. And mobility, no, she's able to move, and it doesn't actually affect her mobility. Yes, she reports partial. She usually says she gets a bit of relief after taking the morphine, but then she's saying it doesn't last longer. And as a result, the morphine had to be increased from 5 milligrams QID to 10 milligrams QID. Okay, we move on. Duration, yes, we've mentioned it has been there for more than 8 months, which is around August. And the pain location is on the right breast, and it's radiating towards the axilla. The scale is between 4 and 5. It's severe pain according to her. Duration, we've covered that as well. Possible cause, it probably could be it is this progression, but we cannot also rule out that it could be emotional pain, as like we have been saying that we are still trying to find out where actually we are in terms of what is actually the main cause of the pain. But yes, there is disease progression which may cause her to experience severe pain. But also tamoxifen, one of the side effects of tamoxifen, like we have mentioned before, it may cause pain on the tumor side. It may also cause that reddening, probably inflammation around the tumor side. So yes, there is a possibility that it could be the disease, it could be the side effects of the treatment. Also, it could be psychological or emotional pain. Treatment, she's currently on morphine 10 milligrams. And we are also continuing with non-pharmacological interventions and symptom management. We still continue with that, but currently she's on 10 milligrams of morphine, the syrup this time around, because initially she was on 30 milligrams BID, the MST, but she's currently on the syrup so that we are able to titrate as per need. Otherwise, it was a bit difficult dealing with that while she was on the MST. Progress following interventions, including your non-pharmacological interventions, the client remains calm because from time to time we try to explain to her that particularly, okay, because we are not explaining to her the staging, but then we try to allay the anxiety. Then she remains calm as opposed to the time when she came here, because when she came, she was a bit aggressive, she was a bit violent, and she couldn't make sense, or she didn't have insight of what was actually going on. But currently, you are able to have a conversation with her. She would respond appropriately, and the memory is okay. So according to our assessment, yes, she is calm. Then pain, we think it is controlled because after taking the medication, she doesn't report the pain, except the pain is usually associated with the bleeding and stuff. Otherwise, after taking medication, she doesn't necessarily report the pain, not unless she sees the bleeding and sees those masses, particularly when she's going for changing dressings. So what we normally do before she changes the dressings, we usually give a morphine prior to changing the dressing. Yes, we continue with wound management. At some point, there was a discharge. I wouldn't say necrotic tissue, but it was just a discharge, a bit of pus. But lately, it has been a clean wound and like a fresh bleeding wound. Significant surgical history and medical history. Yes, she had right breast mastectomy. No other chronic illnesses are reported apart from the mental disorder. Medications, she was on adriamycin, cyclophosphamide, paclitaxel, which she had been taking for quite some time. And of note is that adriamycin and paclitaxel have got a potential of actually worsening bleeding because they actually tamper with the platelet count. So amongst other reasons why the treatment was changed, it was because of that. So she was put on tamoxifen, which is a bit friendly. The only issue with tamoxifen is the issue of causing pain around the tumor site. And also our client is on risperidone. Please note that while giving, because we are dealing with the cancer, we are dealing with the mental health disorder, we are also dealing with pain. So now you have to balance whether there's three conditions, whatever medication you give, you do not have the other one interacting with the other one. So we had to put tamoxifen together with risperidone, which is, I think the issue of risperidone was, okay, you're moving too fast. The issue of risperidone was actually an advantage for us because initially she was given, she was treated for the mental disorder at the psychiatric hospital. So fortunately for us, risperidone is actually suggested that you can use risperidone together with tamoxifen because it actually helps with hot flashes as well. Tamoxifen can actually cause hot flashes. So risperidone is quite good. It's compared to your fluoxetine and other antidepressants. So also you have to consider that when you're giving your morphine, doesn't it interact with your tamoxifen and your risperidone? So it is quite a good combination, which is why we feel like the interdisciplinary approach works very well for us rather than the multidisciplinary. So you will note at the end that we actually emphasize on the interdisciplinary approach in dealing with cases like this one. Yes, she has been on antibiotics, your amoxiclav, your metronidazole, tranexamic acid for the bleeding, your omeprazole, diclofenac, because when she reports the pain, you really feel like you need to do something, isn't now. And the morphine was initially 5 milligrams, but she's now at 10 milligrams QAD. Social history, she's not working. Education, we were not clear how far she went. She's not employed. And socioeconomic class, they are low income. Yes, on the marital status, we left that query because we are not quite too sure whether they separated or because sometimes she would tell you that she went to see the children at their parental home, but sometimes, yeah. So we're still not sure whether they remain married or they are separated. But according to her, she doesn't want to go back there. No alcohol history, no smoking. Advanced directive, oh yes, there is no known history of any related condition to what she has. Because according to her parents, no one has ever had cancers. It has only just been her. Advanced directives, do not resuscitate, orders not done, advanced decision not done. Yes, mental capacity was assessed. And yes, our client is already on treatment, but also from time to time we do mental status examination. Review of systems, the blood pressure is, in fact, most of the vitals, they are pretty stable and they are pretty normal. The pain score, we did access, sorry about that, it's between 4 and 5. And functionality status, sorry, she's ECOG 1. She's able to do lots of other things, particularly when she's stable. The score here, the pain score is 4 to 5. There is no dyspnea, anxiety is there, agitation is there. Depression, yes, you will have depression, but then again, you will have a challenge trying to use the PHQ-9 form to assess depression here because our client is already on risperidone. Actually, she's already on treatment, and it is also difficult knowing, for instance, whether the changes in sleep pattern are due to depression or due to the underlying condition or due to other factors. So the issue of depression, we put it at 1. Yes, sometimes she presents with a bit of this and that, but we could not specifically say yes, it's mild depression because it could be due to other underlying causes. Drowsiness, yes, she reports drowsiness because sometimes you actually find her sleeping. Sorry, can you go back a bit? You're moving faster than I am. A bit up once. Okay, no anorexia, no nausea, no constipation, no dry mouth, mobility, she's okay. And focus test we did, yes, there are lots of other tests that were done, but the one we wanted to focus on was the HP. At some point it was around 8, with normal reference, which is supposed to be between 12 and 15. Yes, she was transfused and she was fine afterwards. Then imaging, yes, there is a CT scan which was done last year, August. It showed multiple nodular masses in the right axilla and probably lymph node metastasis. There's also that seroma, which was reported. Then our plan here is to continue counseling for client, but obviously considering if she will manage to take whatever we're discussing with her. But also we really need to do a health education and counseling for the family to discuss goals of care, because according to the social worker, at some point when she went to do that home visit, the father was like, why can't, or he wishes we could just remove the breast. So we felt we need to do proper discussion of goals of care with the family. Unfortunately, for now, we feel it's not safe to do with the client. So we really need the family to come over. We're still hoping they will be able to make time and come over. Yes, the social worker did a home visit. We hope if resources permit, we hope we'll manage to do another home visit again. So in the meantime, we continue with supportive care, wound care, continue with chemotherapy, which is palliative at this point. Also, we need a family. You had rightly put on your presentation, Mr. Mahlangu, that we need a trusted family member who would actually do the direct observation, whether the client is taking medication, all medication as prescribed or as directed to. We also need to make emphasis on the interdisciplinary approach when handling cases like this one. Like I had said, it was by far to our advantage that the National Psychiatric Hospital decided to put her on risperidone as opposed to other antipsychotics and other antidepressants. So we feel that we really need to use the interdisciplinary approach as opposed to the multidisciplinary, because as it stands, you find that the client has to go to the psych, do her refills, assessment and refills that side, come back this side. So whatever that is happening is just, they are running their parallel treatment and we are running our parallel treatment this side. I think that would be it from our side. Yeah, I think that would be it. Thank you so much.
Thank you very much, Thandazile, for a clear and precise case presentation. At this moment, let me allow questions, comments, or advice. We do have a hand from Tani.
Okay. Thank you once again, Thandazile, for the clear presentation. Mine would be to come from the end, that if the client hasn't been referred to hospice yet, we would love to have a referral so that we can also be able to address some of the other issues the client has, especially the psychosocial issues. And also maybe to ask if with the client taking morphine, if she is on any kind of laxative or not. That would be all. Thank you.
Okay. Thank you so much for that. Yes, she is on laxative. And fortunately or unfortunately, yeah. Okay, unfortunately, I don't know. We think we still have to work around on our referral system, because for now, whatever we're doing, it's substandard. But yes, fortunately enough, it's one case that actually the transport going there, I think this is the case that we had transport from Hospice. So yes, they've been doing follow-ups. I checked with the social worker. The last time, I think our nurse from Hospice was supposed to get information, but I think there was communication breakdown because he needed to know whether for him to discuss goals of care with the family, that to have information like from our side. Otherwise, it's one case your office is aware of. Yes, we do acknowledge that we currently our referral system is just substandard.
Thank you, Thandazile. Any other questions or comments? We do have a hand from Nompumelelo.
Thank you very much. Good afternoon. I'm sorry I've been trying to join and I've been failing this time around, but I'm happy at the end I managed to join the team. I heard Tandazi talking about the patient being on morphine, which she is getting TID. May I please get it clear, because I also heard talking about pain that the patient is always complaining of, and then when he is complaining of that pain, they give her diclofenac. I think I needed to hear clearly, how do they give the morphine to the patient, please, Tandazi? Then I can go ahead from there after hearing how they give the patient the morphine.
Okay, I think we said it's morphine. She's currently on morphine, 20 milligrams QID. Yes, it's QID, because initially she was on, initially when she came here, she was on MST. It was morphine 30 milligrams, which she was taking BID. Unfortunately, we felt like it's a bit difficult titrating or working around the MS2. So we had to move back to the syrup. So we started her on 5 milligrams QID, obviously considering breakthrough pains. So the 5 milligrams didn't seem to be working for us. Then she was moved to 10 milligrams QID. But also we did highlight that for now we're still trying to strike a balance, whether the pain is severe physical pain or it's due to the other stresses. Because what we have noted is that when there's the other stresses present, then she would be a bit agitated, a bit anxious. In fact, when she sees blood, that she gets a bit anxious. So now we have to kind of find out whether the pain, the severe pain, is it physical pain or it's more of psychological pain.
Oh, okay. Thank you very much.
Issue of diclo, sorry, my dear. I think issue of diclo only appeared once. She was given diclo when she came and she was reporting severe pain. So she was put on, she was given diclo. IM, it was IM. It was just a stat dose. Then she continued with the morphine, and she also has MR laxatives together with the morphine.
Oh, okay. Thank you very much, Thandazile. I'm just looking at the fact that even at night or nocturne, you continue to give her the same dosage like you've been giving even during the day. Looking at the fact that the patient will be asleep, she won't be able to be woken up every 4 or 5 hours to be given the morphine. Maybe if you can double it at night, maybe the pain would be controlled there. And then thank you very much, for considering the fact that the pain might be not only physical, there could be psychosocial pain, spiritual pain. I do understand that part, but maybe it's just a point on the evening or nocturne dosage of morphine. Thank you.
Sorry, it's just a follow-up. I want to get it clearly. So, because we were doing QID. So what's the now we are going to double the dose in the evening so that we do not get to wake her up during the night. Or I'm trying to.
Yeah, it's not necessarily doubling the dose, but making sure that the patient gets enough sleep at night. Maybe we can start with I don't know how to do it, but maybe we can start by doubling it and then assessing whether it is working. At what time does the patient wake up and then complain of pain, so that we also consider the breakthrough pain. But actually, I was just looking at the last dose at night before patient goes to sleep. How about we move around it just to make it some sort of giving the patient enough time to rest, especially at night. I don't know what else who also can add on that part of morphine at night.
Sorry, maybe before they add, my dear. Okay, I did mention that the client says she never wakes up because of pain.
Oh.
That is why we were even suspecting maybe it's not actually severe physical pain, but rather the pain could be associated, because each time she sees the bleeding, the masses, then she would report the pain. That is why we're trying to strike a balance, whether is it physical pain, because she never complains of waking up during the night because of pain, and her mobility, she's quite mobile. That's why we felt like maybe it's not severe pain, but then we cannot totally disregard that she has the pain because of the disease progression, because of probably the side effects of the treatment, because of other issues. So that's why. Otherwise, she doesn't wake up because of pain.
Oh, okay. It's okay if the patient doesn't wake up at night because of pain. Then we can look around for the other causes of the pain. I understand that you are saying she always complain of pain after seeing maybe the blood or those discharges that are there during the day. Maybe you can work around that part, because it looks like it's not necessarily physical pain. Yeah. Thank you very much, by the way. I now understand.
Thank you very much, team, for participating in our today's session. I don't know if there are any other questions or comments. We do have one from Mercy.
Thank you, Thandazile, for the case presentation. I was wondering what are some of the challenges that your team encountered coming to the point of probably not being able to disclose the staging to the client and maybe preparing doing so with the family.
Did you get that, Thandazile? Thandazile, did you get what Messi said?
Sorry, she's a bit soft. We couldn't get her well.
I'm sorry, Thandazile. I was saying thank you for the case presentation.
Okay.
What are some of maybe the challenges, or what has maybe led to you making the decision to probably disclose the staging to the family members rather than the client?
Okay, because of her, firstly, it's because of her mental capacity. That's the first thing. Secondly, for her, once she gets, could it be bad news, or she says anything that's according to her she can't handle it, then the condition, the psychological condition, it worsens. So now we are trying to kind of explain something that will kind of depress her and have her relapse on the psychological management of it. So we're trying to kind of tread carefully until we see that, okay, she stabilizes then. But in the meantime, we felt maybe it's okay for the family to understand, so that they don't expect her to be coming here and expect to have a breast removed, yet that is not going to happen.
Okay. Thank you.
Yeah. Yeah, we could have missed it, but we felt like maybe let's not rush into actually telling her what's actually going on right now, like the finer details. But yes, when she complains about the masses, then we would actually talk about that. Oh yeah, we do realize that the masses are actually worsening as opposed to the other time when you came. The bleeding, we usually talk about that. At least it's something that we feel she can handle. Well, we could miss it. We might think she might not handle some of the things, yet the client would actually handle that.
One last question. In terms of selecting the family members, how are you planning to go about that? Because she's married, but at the same time, she's staying with her parents.
The client, like I said, on her spirituality, she said she's very comfortable. Whatever that happens, it should be done with her parents. So according to her, the people that we can use, it's the parents. Yes, she has siblings, she has other relatives, but she's comfortable with the parents. And amongst other things that she actually requested, amongst other things, was that can we really do counseling for the parents? Unfortunately, as they haven't gotten over as yet, so we're still expecting them to come so that we actually do justice, like discuss goals of care and also provide counseling for the parents, as she had rightly requested.
Thank you very much. Thank you very much, Thandazile, for what you've just said. Let me just give a minute to Mr. Mahlangu before we close.
Thank you so much, team, for today's session, and thank you so much for this wonderful case. I will suggest that always look for laxatives for such patients, always when you are considering using the opioids. And also, though we didn't discuss it today, but maybe you will consider also, I don't know, the indication of 4 times a day instead of 4 hourly. I don't know how, but consider the indications of the morphine given 6 hourly instead of 4 hourly. That also would expose the patient to end of dose failure, or before we can consider anything considered as breakthrough pain, we need to consider that one. I would say how frequency is the frequency enough to meet the patient needs. Then if is the blood analysis that requires us to reduce the frequency of the morphine, then it's fine. But if it's not, due to that or else sedation, and then I will recommend that we go back to a 4 hourly dose. We better reduce the dose other than the frequency, because we want the morphine to be there in the blood, as of it might be difficult to control an existing pain, especially once the pain shoots above 5, it will be a little bit of a challenge. So maybe go check even the frequency adjustment. Was it due to blood or analysis, or it was just side effect? What is it? If then there was none, it was just assumption, I will request we go back to the 4 hourly dose, which will make it 6 doses. But if then there's a side effect, we'll reduce the dose first. But if the blood analysis are doing that, in the absence of hydromorphone in the country, we may find ourselves then maybe reducing the frequency. And then in terms of the breaking the bad news, I will say, to me, she sounds sometimes able to make some decisions, engage her in terms of that you need to discuss some other issues concerning her medical status, and then concerning the plan. And you'll find that some of the issues that are here because of the status in my mental health status, you will discover that some things will be challenging. But then I hope you will better encourage the patient to come with his or her caregiver or immediate person, or if possible, his process decision maker to the facility every time she comes, to avoid making decisions that may not be tomorrow be able to continue with it due to mental status. Also to avoid delaying making certain decisions in terms of care. because it might take you some time for the parents to come to the first. But if she did came with her process decision maker or an immediate caregiver whom she think can be there to help her make decisions in the facility, you will be able to then discuss in terms of, if we want to discuss those bad news in terms of treatment going forward of the goals of care. She will then say, maybe I will discuss with my parent. But now you may be struggling to even to get who will make the decision in the family. So I would advise, encourage you to bring the caregiver always when it comes to you, so you are able to move forward in terms of decision. Because now I feel like there's still no operation that has been done, and yeah, it's gonna be a challenge. So that's what I will say. My advice would be that. And thank you so much for attending to this session. We have learned so much from this case, and we hope to learn more from it. Thank you so much.
Thank you, colleagues, for attending. Unfortunately, our time is up. Please do remember to click on the feedback link and share your feedback. Our next session is on the 19th of April. We'll be tackling the topic, managing pain in patients at risk for substance use disorder. Thank you very much for attending. Happy Easter. Bye. Oh, I'm going to be here.
Bye-bye, everyone. Concerning the session on the 19th, see how we deal with it, because it's a holiday. So we'll get notification via your emails. On the next session, the email will be available for you.
Okay, bye.
Bye-bye. Remember to click
Bye.
Bye-bye. Remember to click on the feedback link. Just dismiss.